Welcome to the new iWorld live studio and this live event with the most live person here, Amar Agarwal. You always bring these really new, really cool things. So let me kind of set this up. So there is a lot of talk about intraocular lenses with pinholes specifically for patients with irregular corneas, with astigmatism that's very high, who are not contact lens candidates, not amenable to other treatment. These people have had very few options. Now you're addressing this, except there's no IOL, there's nothing that needs approval. What's the magic? How's it working?
The name of the technique is pinhole pupilloplasty. And that name was coined actually by David Chang. He told me this name and I thought it's a great name. The basic principle is very simple. The pinhole IOLs are great. The problem is you need US FDA approval. One, they are costly. Two, I should be able to have them also. They are not available easily in the market. So instead of going for that, what we decided was, I thought let's make the pupil a pinhole. So I don't need an IOL. The camera inlays work at the corneal level. The IOLs work at the IOL level. What we are doing is we are working at the pupillary level. And this is done by any pupilloplasty technique. But I think one of the easiest is the single pass 4-throw pupilloplasty. Now another very important thing is you have patients with high astigmatism, keratoconus, corneal injuries, any scarring. There are a dime a dozen conditions with high astigmatism post PKs. The problem in all of them is the patient has high astigmatism. You have done a great keratoplasty, but patient is not seeing. Now, if you analyze their angle kappa, that means the terminology started by Daniel Chang and George Warren IV is chord mu. And I have to give credit to Jack Holliday, who taught me more on chord mu. So if you take the visual axis and the pupillary axis, there's a distance. It should not be more than 0.4. And if you see these patients, it will all be more than 0.4. Now what we are doing is, we are going to bring them closer. That means I'm bringing the visual axis in line with the pupillary axis, decreasing the chord mu or the angle kappa, personalizing a chord mu for that particular patient, which has never been done before. And this way, the patient sees distance and near without glasses.
So this is really interesting stuff. And I understand conceptually what it is that you're doing. I don't have a good sense of how you're doing it, but you've always been generous with us with bringing video, and you've done that today. So why don't we turn our attention to the video now, and you can explain how all of this stuff works.
Let's look at that video, and you will see how the surgery is done using the Purkinje image of the microscope. All microscopes have the Purkinje image, and all we need to do is focus that and center the Purkinje image.
Let's go to the video now.
See the video there, Josh, and to the viewers, all of you who are watching it live, that's pinhole pupilloplasty. Look, we have made the pupil 1.5 millimeters. So all the peripheral rays of light are blocked. The Stills-Crawford effect comes into play because only the central rays are effective. Now notice, if you have a small aperture, the patient sees distance and near without glasses. And finally, a phenomenon called vignetting, where the periphery gets darkened to highlight the center. So what are we trying to do basically here is, we can try to make the pupil small. This has been done with the corneal inlays, with the pinhole IOLs. But what we are doing is, we are playing this game at the pupillary level. So if you see in this animation, I made the pupil 1.5 millimeters. The peripheral rays are blocked. Only the central rays focus the image onto the fovea. Now let's look at the surgical technique. And you can see the difference between a pinhole IOL with a pinhole pupilloplasty. Now this patient, as I showed you before, has got high astigmatism. Notice I fixed a trocar AC maintainer. That gives fluid in the eye. It's made by Mastel. Now, My next step is I can always keep on injecting viscoelastic when needed, but here you notice I'm doing the fourth throw pupilloplasty. So take a 9-0 or 10-0 proline suture with a needle, pass it from one end. The other side has a 26 or a 30 gauge needle, railroad the two and bring the loop out. Once the loop is out, remember the number 4, 4 throws, and that's done. You don't need to do a second throw. You don't need to do a third throw. Now, next, you can keep on doing as many single pass, 4 throw pupillasties as you want. Notice I have an endometer in the other hand also with my assistant, which gives me better visualization. Now look carefully. The pupil is decentered. It was decentered before we started the surgery. So why is it important? Because as I told you, we need to make the visual axis and the pupillary axis together. So I'm going to focus on the Purkinje 1 image. Now notice I'm bringing the pupil down slowly and steadily, but still it is large. So I'm going to use the vitrectomy probe, and I have fluid in the eye going on at the same time to see my pupil becomes centered. And now look, my pupil is centered, Purkinje image falling in the center, but if you notice the top portion is still quite large. So I have to do some more 4 throw pupillasties to close the defect on the top, so that I get approximately 1.5 millimeter pupil. Remember, this case has a endothelial keratoplasty done, a predestined endothelial keratoplasty done, and still everything is going smoothly. Look at the final picture. I'm using the vitrectomy probe to make the pupil centered, and you can see the Purkinje image bang on the center. And that gives you approximately 1.5 millimeters. Now the question comes simple. How did this patient behave? And you can see here at the end, the Purkinje image bang on the center of the pupil. So let's see how the patient is preoperatively, on table, and postoperative day 1, 612 N6. That is J1. And 2 weeks, patient is already 612 without glasses. The specular microscopy was pretty okay. The phenomenon of diffraction we should remember, because if the pupil is 1.5, you're comfortable. If you make it too small, the problem is the light rays bend and then you'll be in trouble. So angle kappa or chord mu, you can see the distance between the pupillary axis and the visual axis, we are bringing it closer. And as I said, we are personalizing the chord mu. Look at the astigmatism. It has not changed, but the vision has improved. If you see this picture here, the cross shows the pupillary axis. The white circle is the visual axis. And see the post-op picture? They've come together. If you see that minus 0.7 and 6 has become much smaller, that is the chord mu. And that is through a Pythagoras theorem calculation, it can be done. So you can see the pre-op and you can see the post-op, how the patient looks.
Fascinating stuff. Yeah, really, really, really interesting. Let me. I've got several questions always. One of them is this: are these cases done under topical? And the reason there are two reasons that I ask. Number one, you can only rely upon the location of the Purkinje image if you can actually have the patient fixate on a target, which I guess in this case would be the microscope light probably. And number two, if it is topical, how do the patients tolerate this manipulation of the iris?
I personally prefer to block the patient. And very simple is, I understand the point which you're saying the patient has to look. So what I do is I see that the chin is bang perpendicular to my microscope light, and I see it's bang centered. There might be slight discrepancy from that to an actual thing, but from what we are seeing in our results, it is pretty okay. I can do it under topical, but the problem will be that suppose by chance I'm manipulating too much and the patient has slight pain, there will be a problem. So I prefer to block it, at least now. In the beginning few cases which I'm doing since 1 year, I've been doing pinhole pupillasty. So I prefer to block it. But what I tell patients is to bring the chin up so that we are flat and perpendicular to the microscope light.
Yeah, really, really, really interesting. And the cases that you showed, and you always make things look so Easy, Amar. The cases that you showed, those were all pseudophakic patients. Do you only do this with pseudophakic patients?
If a patient is phakic, I will make him pseudophakic and finish the surgery. The reason is very simple. While you're manipulating, you might create some cataract.
Yeah.
So if I have, let's say, a post-PK patient who has got lens already inside, he's a 50-year-old, 60-year-old patient, I'll make him pseudophakic, and at the same time, I will finish off the pinhole pupilloplasty. But the idea is, I don't want him coming back to me for another surgery. There are patients with keratoconus, huge bunch of patients who are older patients, 35, 40-year old, but having 10, 15 diopters of astigmatism, not happy. In these patients, what I suggest is the results are mind-boggling. Actually, if I do them in the morning and I see the patient in the patient evening will be already 612 to 69 vision.
No, really, really, really something. So I want to spell out something that you said, and you said it very clearly, but I want to make sure that the audience understands. There are limitations to the size that a pinhole aperture should be in terms of optimizing the quality of the patient's vision. If it's too small, then there's diffractive degradation. If it's too large, obviously, then it's not a pinhole. The camera implant has an aperture, I think, that's a little bit more than 2 millimeters, but at the IOL plane, the optimal aperture size is something like 1.5. Yeah, which is what you're doing. So the number's not coming out of the blue. I mean, this is the sort of what the consensus number is. Yeah, just absolutely fascinating stuff.
I just want to tell you something on this diffraction, because if you make the pupil too small, just to tell the audience, the rays start bending. When the rays start bending, they don't go to the center, then the whole effect of the pinhole is gone. So that's an extremely important. And if you stick to the Purkinje image and go around it exactly, you will get 1.5.
Yeah, that's a great point.
We already created also a pinhole marker, which is about 1.5. So if you want, you can use a pinhole marker, which gives you also another extra benefit. You can pass the pinhole marker inside the eye or keep it on the corneal level, but you'll get an approximate idea that you're getting a 1.5 millimeter pupil. But the Purkinje image makes life so simple because you are making the pupillary axis and the visual axis together. And our paper on this is on pinhole pupilloplasty is in the May issue of the JCRS, and another paper with the cord mu is soon coming out in the JCRS again.
Yeah, just fascinating stuff. How do you come up with something new every year, Amar? You're amazing. Listen, I want to thank you for being obviously so generous with your time, creating this innovative thing and then explaining it so very clearly, and always your generosity with your videos. And I want to thank you for being one of our first guests in the new iWorld Live studio, and I want to thank you, our live audience, for participating in this live event. I always learn so much from Amar, and I know that you have too.
This iWorld Live is something everybody should be watching, actually live.
Tell your friends.
Tell all your friends to watch it.